We are now talking with Dr. Julia Hammond, who's a general practitioner from Manchester, United Kingdom. So if you raise your hand, Lynn, yes. Dr. Lynn Jarter, who is anesthesiologist from Swansea in Wales, which is western part of United Kingdom. And Dr. Paul Garner, who's a professor of infectious diseases at Liverpool School of Tropical Medicine. Thank you very much for joining us during this important program. We'd like to learn more from about COVID-19 and about protracted symptoms of COVID-19 from your perspective as a patient as well as doctors. So let me start with Dr. Garner. I read your article in the British Medical Journal about how you describe a roller coaster of ill health, extreme emotions, and auto-exhaustion. So you explain those symptoms as protracted COVID-19, and a doctor call it this as post-viral fatigue syndrome. So Dr. Garner, you are a healthcare professional with quite extensive experience. And I assume you're practicing social distancing and other measures, and also you have many years of running and military fitness, but yet that did not protect you from contracting COVID-19. Why do you think this happened?
Well, at the time, we all actually contracted COVID in the week or so before lockdown in this country. And at that time, the disease had a doubling rate of about 3 days. So that means that the cases were increasing exponentially. And I work in a setting where there are many doctors coming and going, both as students and as staff. And I assume we all practice social distancing. We were getting ready for lockdown, but somehow I contracted it in that stage that Boris was talking about herd immunity. And I personally...
Excuse me, we're talking about Boris Johnson, the Prime Minister.
Boris Johnson, yes. So it was
okay.
At the week when everybody said, oh, we don't have to lock down, we'll just everybody will become immune, and a few people get ill, a few people will die. But during that, so I got infected during that time, and I became unwell, feeling slightly strange. I couldn't explain it. I had no fever, I had no cough, I had no shortness of breath. I just felt a bit odd, and in the light of that, decided to self-isolate, and that's why I did. And I honestly thought that the illness would be quite short. I said to a friend, I think I've got COVID. He said, well, you'll be unwell for 2 or 3 weeks and then you'll get better. If you get short of breath, go to hospital. And that's what I expected to happen at the beginning.
Yeah, so Dr. Hammond and Dr. Jarter, Dr. Garner mentioned that your Prime Minister shaking hand and not wearing masks, was it misleading message to the public? Did it affect you somehow? Of course, everybody at that time among medical community knew that the pandemic is coming. But could you tell your story a bit, how this happened to you?
Similar to Paul, it was before it had fully turned into lockdown. So my hospital had just started preparing for the wave that was about to hit. But at the time when I got infected, we were still running normal surgery. So I just had a weekend on call. And I was on my second day off when I got a little bit of chills and was sort of wondering, oh, maybe I'm coming down with something. And then I walked just from my car to my front door. And as I was unlocking the door, I realized I was short of breath. And I'm normally very, very fit and do a lot of sports and activities and hike mountains and cycle everywhere. So walking from the car to the door is absolutely not the normal me. So I knew that something was wrong. And then I just went inside and quickly deteriorated. So by that same afternoon, I was basically bedbound, with a flu-like illness, but with the COVID hallmark of the shortness of breath and the dry cough as well. And then I was ill for about a week or so, in bed the whole week. And then I also developed sinusitis, an infection in my sinuses, and struggled along with that for another week or so. But then my story is a bit different from Paul's, because I thought I was well again. So I felt fine, and I was able to go back to work again. And by that point, work had then changed into us fully taking care of all of the COVID patients. So elective surgeries had been cancelled, and I was instead working in our intensive care unit that was only taking care of COVID patients. And that went on for about a month, when I then went on to develop a second sinusitis. And then with that came the intense fatigue and myalgia that then left me absolutely bedbound.
So I gather, Dr. Jata, that probably in your case, this was nosocomial contamination, right? Or did you think about that?
Sorry, say that again.
Nosocomial, it's inside the hospital. So the way how you contracted COVID-19.
It's obviously hard to say exactly where you get it, but I had pretty much only been at home. I must have done grocery shopping at some point, but that aside, I'd only been at home and at work. So chances are most likely that I contracted it at work, but it's of course impossible to know.
Thank you, Dr. Hammond. So you also worked as a general practitioner. Do you think that this is also like, the way how you practice medicine? Were you provided with personal protective equipment, PPE, at your hospital, your practice, or maybe you have different story?
So I'm actually training to be a GP. So I was actually on a job in the hospital. I was doing obstetrics and gynecology at the time when I contracted it. And we were not using PPE at that point. I was involved in 4 or 5 clinics the week before I fell ill, that I had many patients that came in coughing. And so I think, I mean, again, it's hard to know. I was the same. I was at work and at home. I maybe did a little bit of grocery shopping at some point the week before, but I think it's very likely that I contracted it at work.
Okay, so it's a occupational hazard. Obviously, many doctors in Kazakhstan, in the United States, in New York, lots of disproportionate high level of COVID-19 infection among medical professionals, unfortunately.
And at that point, we were not wearing PPE at that point. So we were, like Lynn, we were getting ready to sort of have the PPE and, getting the masks ready, but I didn't have protection at that point either.
So apparently, as we know now, is COVID-19 is not just respiratory disease or prolonged fatigue syndrome. So there's a study by King College London that quoted that tracked the progress of more than 4 million COVID-19 cases in the United States, Sweden, and the United Kingdom. And so besides well-described symptoms, as you described, which is fever, cough, many patients have loss of smell and others. There are a lot of other symptoms such as skin rash, headache, abdominal pain, diarrhea, and many, many others. So apparently COVID-19 affects many organs and systems, including brain inflammation, causing confusion, reduced consciousness, stroke. Also, it affects small capillaries, as far as I understand, the endothelium, the blood endothelium, blood vessels, and which supply blood not only in the lungs, but many other organs. And this may cause blood clots, damage in kidney, heart. So I understand from what you describe and from your article, Dr. Garner, is that this is not a complication of main disease; it's a protracted symptoms. It's something that you continue having the main illness for almost now 6 months. Apparently, all of you contracted COVID-19 in mid-March, so it's been almost more than 5 months today. So you think it's a protracted disease, or it's a complication of main disease? And could you explain us as why that?
Well, I think it's a new virus that is not well understood and causes a variety of disease, different conditions in different people with different mixes, and we are only just beginning to understand it. So that in a sense, the textbooks about this condition haven't been written, and the people that know most about the condition often are doctors that have got the disease almost as much as the clinicians that may be treating some of the complications. So it's a very, a lot of the information that I have got about the condition is through my own experience and through looking at websites and having a high suspicion that almost anything can be due to COVID-19. And I remember when Lynn was describing her sinusitis, we put that on a Facebook page, and suddenly it was very clear that sinusitis could be a presenting thing with COVID-19. So I think if there's a message to people in your country and the doctors is be suspicious of anything that looks a bit unusual and have an open mind, because this is a new condition. And you also asked about the length of the illness, sir, and indeed quite a lot of people have a mild illness and get better. But there's a lot of people that actually have this much longer set of illnesses, which are really quite incapacitating, affect people in the way, like me, I've just been fatigued for these 5 months. People like Lynn have gone back to work. So many different syndromes. It's a whole myriad, a whole spectrum of conditions.
Interesting. So apparently, three of you developed similar symptoms, and I would describe them as a fatigue, headache, brain fog, but probably Dr. Jarta has sinusitis, but that distincts from you two. And also myalgia and neuralgia and these kind of symptoms. So it's been 5 months. Could you tell us, as a patient and as a doctor, so now you're looking, I assume, much better than it was 5 months ago, but what was it that helped you to recover from that, or, like, improve your condition since March?
I mean, I had fatigue and feeling unwell and all these headaches and all that kind of thing. But Lynn and Julia had quite different conditions. It might be worth just hearing from them about the fatigue or the conditions that they're left with at the moment. Lynn.
Yeah, so when I gradually came out of, because with the initial brain fog, I had initial fatigue, I had very severe brain fog. So I think the first month was just one big muddle. But as I gradually came out of that and sort of reflecting back on the time and sort of also starting to put together what was actually happening to me still, I realized that throughout this whole time, I've been troubled by a really fast heart rate from just walking a few steps. So just taking 2 steps, my heart rate would be double my normal resting heart rate. And that's still causing me an awful lot of issues. So that's probably been my main thing, apart from the fatigue.
Whereas for me, sorry.
Yeah, go ahead.
I
Yes,
was going
Dr.
to say,
Hammond.
whereas for me, my main issue still is the shortness of breath. And I've got what feels like a band around my lower rib cage that makes me feel as though I can't expand my lungs properly. And it's an odd thing because initially, you know, I was only able to walk sort of 900 steps a day in the early days when it was at its worst. Now, I'm still short of breath at rest, but actually when I'm walking and I've slowly been increasing my exercise tolerance, I feel much better when I walk. It feels as though I can expand my chest a bit better and my breathing is good as I'm exercising, but then I pay for it for 2-3 days after. So that's my most limiting symptom. I still do have the fatigue. I've had a headache as well now for over 140 days. It is getting a bit better, but initially it was the worst headache I'd ever had, and it was accompanied by a trigeminal neuralgia on the left side, as well as sort of a scalp, occipital kind of scalp area burning, just odd sensation. And so those things still remain for me, and I'm still actually getting the chills. Not all the time, but when I'm tired, if I push myself too hard, I'm still having some of the same initial symptoms. And so for me, my most worrying issue, I think, is the shortness of breath.
So I assume all three of you confirmed your diagnosis with a PCR test or some serology. Is that correct?
I did eventually get some antibody tests done, and they were positive. To be honest with you, when people have the disease, they know they've got it. I'm not even sure whether Lynn and Julia have had tests. I couldn't have a PCR because there were none available at the time when it would have worked. The antibody tests are almost completely, I mean, they rule in the disease, but a negative test doesn't rule out the disease because that they're so varied in their quality. They don't become positive until at least 3 weeks in, and then probably become negative again. So it's a big issue in our country at the moment. Lynn, did you? I can't remember if you had a PCR.
I did. I actually had a swab test at the right 3 days after I started getting symptomatic, but it was negative. But both my GP and I quickly established when my relapse came that it definitely must have been a false negative. Because my symptoms are just so typical of what's happening to us all.
Yeah, so basically based on clinical presentation that you diagnosed.
Exactly.
COVID-19.
So
Is it quite common in the UK that without PCR testing this COVID-19 diagnosed?
So the PCR, the validation in the UK has been on samples in a laboratory that are known to be positive. And we know that the sampling method and swabbing the nose will lead to many false negatives. So there is real problem with that. With the antibody tests were introduced in the UK on the basis of 20 samples from the manufacturer. So that was the evidential basis for these tests being brought in. So basically, you have untested new technologies in place where the implication of a false negative can be massive in terms of what it means to the patient and to the doctor and the employer, but actually the science is such that they are not very reliable.
But still, is it free for UK citizens, or is it provided by NHS?
Yes, it is. Julia and Lynn, I'm not sure how it's organised. I mean, the tests are there to exclude disease in people that feel unwell, I think, when they're most infectious. Isn't that right?
Yeah, I think initially it was pretty much only healthcare workers that were able to get access to them. So I got access since I was a key worker. I was meant to go back and start working ITU. But that aside, the public, I think, pretty much didn't have any access at all. I'm not sure now how the public do access it, but it is becoming much easier for them to access it. But it's all through the NHS and it is for free.
They have these drive-in centers, so they've
Right.
opened up spaces at the airport close to where I am. So it's a vast space. You drive in, you kind of they were having military personnel help to do the swabs initially. Now I think a lot of them are you swab yourself. So obviously that is going to be an issue as well in terms of technique and whether you're getting the swab to where you want it to go. So there's still, I think, even though they're being much more widely available, there's still quite a few issues with how the testing is being done.
And of course, in these circumstances where they're looking for people that might be infectious to others, the swab test may well be useful. But in terms of a definitive diagnosis for people that have lost their sense of smell, are having muggy headaches and feel absolutely dreadful, you would not wish to discount the symptoms in the light of a negative swab or a negative antibody test. And so it's very important that people realize that it's the symptoms that are important, and to learn what they are and understand them. Because of course, if in the UK, the concern really was for people at home, if the disease was said to be mild, people may then discount things happening to their body that indicated that they were having an important complication, as you say, sir, about, for example, deep vein thrombosis in the leg that can throw clots off into the lung. This can happen late. People can have strokes late. So it's very important that people listen to their symptoms to make sure that they are not indicative of something else that is more serious that needs treatment. I mean, I lost my sight in my left eye at a day 110, I think it was. And I was extremely concerned. Other doctors were extremely concerned. I posted this on the Facebook site, and everybody said, "Oh goodness, well, I mean, I've been having that for ages, and I can't speak properly." And others said this is a symptom of chronic fatigue. So here was an example of the patients actually knowing more about the condition than the doctors. But obviously, if people have a disturbance of sight, they need it investigating. And I talked to my doctor about it, and it turned out to be a migraine. Goodness, it's a complicated disease. You have to be on your alert really at all times. And I think it's fair enough when people become unwell again, or they have symptoms that scare them, that they consult with their doctors to get reassurance or get tested if they need it.
Yeah, I'm glad that you're pretty active on social media and communicate with other patients and the medical community, so you can learn more about, and others can learn from your experience, which is very, very important. But this thing, the absence and negative PCR symptoms with the presence, while respiratory symptoms and other symptoms are present, it's very confusing, and especially in Kazakhstan, in terms of reporting statistics, it wasn't clear as whether, like, pneumonia or respiratory symptoms are COVID related. And about a month ago, even the government wasn't reporting those, like, pneumonia cases in summer as a COVID. So this is very confusing. So what you're saying is COVID-19 is a systemic disease, and it affects many organs, including brain, kidney, heart, and we always have to be vigilant about any symptom that comes up. Another important thing is many patients in Kazakhstan who develop respiratory symptoms, they try to confirm confirm it by going through computed tomography. And we heard a lot of things like, 30% damage of lung, or like, 50% of lung. And this was kind of like, an indicator as whether or not that patient needs to be hospitalized. So Dr. Hammond, you mentioned that you experienced shortness of breath. Did you feel that you need to go through the computed tomography screening or diagnosis? And what would you recommend regular patient in this case?
So I think it's a difficult one because everybody will have a varying level of shortness of breath. So Lynn mentioned she had some shortness of breath. Paul, I don't know if you ever had the shortness of breath. There are a few things that I think, when you have this type of shortness of breath, you worry about. Obviously, as a clinician, you're already starting to form a differential diagnosis. So for myself, because it was my main, most worrying symptom, I actually went into the hospital twice. So I went in on day 10, and I think I went in on day 46 or something, maybe a bit earlier than that, day 36. And they did chest x-rays and they did full sets of bloods. There was no evidence of inflammation, and yet it was clear that I was short of breath. Never short of breath enough to require oxygen. But as the weeks progressed, so I don't know, day 142, 43 now, there was a period, it's sort of days 47 to 56, where I was desaturating. So I had my saturation probe, which obviously the average person will not have, but because I have my doctor bag at home, I had. And I was noticing that even the smallest amount of exertion, my blood saturation levels were dropping significantly. And
So you're using a pulse oximeter, right?
I was using a pulse oximeter, exactly. And so I was going into the 80s easily, just walking kind of to the loo or up and down the stairs. And my heart rate was rising significantly. At one point, I think it was 220 going up the stairs. And at that point, I spoke with a colleague, and we have these kind of hot hubs where GP practices were being turned into areas that were only seeing COVID patients. And so through that hot hub, I was sent to the hospital, and I did have a computed tomography. I had a CTPA to check for clots in my lungs. I was also still at that point having very severe stabbing chest pain in one particular area in my right upper lobe. And so I think because it had gone on for so long, and because of the shortness of breath and the desaturation, they did the CTPA, which was completely clear. What they did find incidentally at that point was that I had a paroxysmal atrial flutter. So as I was exerting, that's why my heart rate was going into the 200s, is because as I was exerting, I would go into this flutter, and then I would rest for 10, 15, 20 minutes, and my ECG would be completely normal. And that seems to have resolved. I've since then also had a 24-hour tape and an echocardiogram, and they were both normal. The episodes when I sometimes feel as though I'm going into a flutter are just normal, a sinus tachycardia, but that has improved as well. So I think exactly as Paul said, I didn't go in for all of these tests, even though I had shortness of breath for over a month and a half, until I felt that my signs were such, that I didn't want to ignore it anymore. And other colleagues as well said, we can't really ignore this anymore, go in and have it. I don't know that everybody who has shortness of breath will need a CT scan. I think it's unlikely that that's, very unlikely that that's the case. But I think for those of us that are having these quite protracted symptoms, if something changes or something becomes worse or there's a new symptom, I don't think we can ignore those things. And I think it's the right thing to get the investigation.
And here we have, doctors sick themselves, looking at the literature, trying to work out what's going on, and struggling with trying to work out what this all means. So it means that for people at home that aren't medically qualified, that they do need to be concerned about symptoms and symptoms that change, and they may need some help in checking that there isn't some kind of serious condition, and they need this sort of sorting out before they start trying to do a lot of physical exercise or do a lot of work. I mean, Julia, with those kind of indications of the blood in the oxygen in her blood dropping with very mild exertion, actually for somebody that had a job would probably mean that it would be dangerous for them to go to work until things had settled down.
Okay. Yeah, that's interesting perspective, because the CAT scan in Kazakhstan is inexpensive, but still many people rush to these radiology units to try to get CAT scan. And that turned out to be as one of the criteria for diagnosis, even for hospitalization. And a lot of discussion and uncertainty about that, but there's no conventional wisdom on that at this moment. But more people are more leaning toward sort of like, you know, clinical diagnosis and based on symptoms and determining what to do next. So it's been more than 5 months since you experienced these symptoms. I assume you're concerned about some relapse or some potential serious issues with heart, with kidney, even brain, and somehow this related to coagulation and blood vessels. So how do you monitor your condition? So I assume, of course, you have to monitor probably blood and kidney and maybe blood coagulation. Some patients who spend about 10 days in the hospital, they release and they continue treatment at home. And the way the doctors recommend in Kazakhstan is to check periodically for platelet count, C-reactive protein, D-dimers. So what your doctors, what your colleagues recommended to you to monitor your condition?
So I think it is a bit of a mess, actually. And I think people are getting very uneven levels of care. And I think there is a tendency to over-investigate. I mean, I have a very pleasant and very accomplished consultant who, there was one round of bloods taken from me, and when I had a suspected DVT, a deep vein thrombosis, and bloods were taken, and I had a chest X-ray then. And so for my lungs, I've had nothing, and no further blood tests have been done. In fact, he advised, we had a long discussion about how to get better, and he was advising me that fresh carrot juice and ginger would actually be a very good care. And actually this was kind of a bit strange in a sense, but actually it diffused my anxiety about needing lots of tests and that my body was terribly damaged in some way, because he said, Paul, you've got fatigue, but other things seem to be all right and you seem to be improving. But that's the personalized care that I'm getting that has been very low on investigations. I don't know about the others.
No, similarly, I haven't had a lot done since my main concern initially was really the fatigue. I was absolutely bedbound. I had to, if I had to go to the toilet, I was planning the walk about 2-3 meters, and I would always combine it with making sure that I'm topping up my water, grabbing the next meal from the kitchen, anything to reduce and save the little energy I had. So then I discussed it with my GP as my family doctor, and we thought we'd just do some basic bloods to rule out that there's no other, simple cause of fatigue. But that all came back normal. And that aside, I haven't had anything. I'm waiting for possible investigations for my heart because of the fact that it's been so many months and I continue to have such fast heart rates. But that's about it, really. I've had a chest X-ray as well. That was normal. And I do agree that it is very important to make sure to investigate so that we don't miss anything else, such as blood clots and things that are related to COVID but not COVID itself. But equally, it might not be a good reason to over investigate things.
I see. So your sinusitis is over now, so you it's gone. How it is now?
I had a third bout, so I had 3 bouts in total, and it was with every single bout, they just got worse and worse. I think it's been one of the most severe headaches I've ever had. It was absolutely, absolutely awful. I did everything you could possibly do to treat them. And yeah, so once I finally got out of that, then I felt like I could finally start sort of addressing dealing with the fatigue. It felt like I was sort of ticking off one problem at a time. Yeah.
So until recently, I remember even 2 months ago, it was a lot of uncertainty as how to treat especially severe cases of COVID-19. And some doctors in Kazakhstan prescribed antibiotics, sometimes broad spectrum antibiotics, and a lot of criticism about that. And it wasn't clear, and the doctor exchange uh, uh, information between each other through WhatsApp and some social media, try to find out what are the treatments. But now it became a little more certain with introduction of this cheap steroid dexamethasone, and like they use low molecular anticoagulants. So what's the UK experience? Was it introduced? But unfortunately, for instance, dexamethasone, people are so excited about that medication, and they started prescribing even in mild cases, which is not good idea, I assume. So what was the experience in the United Kingdom? So was doctors also excited and started using those strong medications, I would speak? And how about antibiotics?
So I mean, I have nothing. I mean, you know, vitamin D is pretty good idea, and some. That's about all. I think the hospitals use dexamethasone for people that need respiratory support. It's not routine, even in people on positive end expiratory pressure, those pressure masks to get antibiotics. It's not routine at all. It's only used when a superadded infection is suspected. You know, it's a virus. You know, that's it. There's nothing that's working particularly in this sphere. Now, of course, the problem is that the patients all want something that works, and they're demanding that from the health system, and they're demanding it from alternative practitioners. And if you start prescribing just in case, then you set up this vicious cycle of expectation that it's going to work, and yet there's very little remdesivir and as you say, the steroids in people with severe disease. I don't think there's much else that apart from symptomatic treatment of headaches and so forth. I don't know what the others think.
So you're saying that should somebody experience such symptoms and spend a week or more in the hospital, and then they released at home, they don't need to continue on those anticoagulants or like, you know, steroids or anything else. But still, what needs to be done in order to prevent severe complications? Apparently, some people, as you described, it's a systemic disease and may affect any organ, affecting the heart, kidneys. So what should be done in order to prevent such complications?
Don't get infected.
Don't get infected. So you
don't
believe
get infected. Talking to three doctors, but no, I mean, seriously, it is not a condition I'd wish on anybody. I'd certainly say that practically speaking, from my side, and I don't reflect everybody, but I have this chronic fatigue, and the most important thing to me is rest and convalescence, and learning to rest my mind, learning not to walk more than 3 kilometers, or working out what my limit is on my exercise, not going over that because that will make me ill again. It's practical things like that that doctors need to learn. I was absolutely staggered when I looked at the NICE guidelines from 13 years ago to see that they don't measure, they don't mention post-exertional malaise as they don't mention it. and yet this is a very common condition in people with fatigue. They mention pacing, this idea of keeping below, working out what your maximum is for your exertion, and then coming in below it. They don't describe that well, and it takes a long time to understand it. It's taken me a long time to understand it, and I know Julia and Lynn also sort of have taken a little while to understand it. And there's a colleague who's ill in the street, and the reason I know she doesn't know about pacing was when she walked past the first time. I said, "How are you?" She said, "I feel terrible, but I don't know, I've got to walk at least 2 kilometers a day to try and get myself fit." I said, "You are going too far. Go 100 yards, go home and rest." And it was until she understood that she needed to do less in order for her body to repair that things started happening. So I think general practitioners, rather than learning about lots of drugs and whether steroids work, learning about practical advice to help patients help themselves, I think would be perhaps more helpful.
So no matter how fit are you, you don't need to force yourself to go back to the same fitness level as used to be. Is that true, Dr. Jarte? So I understand that you said that you're climbing mountains in the past, so you no longer do that, right?
Oh God, I missed them. And Wales as well is such a beautiful coastline and loads of hills and mountains. But no, because I've been so severely fatigued that the first month or two, or even still, when I do my grocery shopping, I will take the car to the front door of the store, lean on the trolley, and walk at the slowest pace that is physically possible around the store. And that still exhausts me, absolutely. And whenever I try to push myself, because having the personality that I do, I have so many times pushed myself too much, and it gives me absolutely crazy setbacks. They've gotten better, but about a month or so ago, whenever I did push myself a little bit too much, I'd have a setback for a week when I again couldn't get out of bed at all for a whole week. And then that rest for that week makes it a little bit better. But Paul, he described it very well, that it's all about the pacing, and that's why we have our pacing group together with Paul's neighbor as well. So when we meet weekly on Zoom calls like this and chat and talk through it. So we basically pacing, the principle is both the resting itself and not pushing through, but also the principle so that when you do something, so say for example this morning I got up and made breakfast, and then I would go back to bed and rest after the breakfast. And then I would go up and have my shower, and then I would go back and rest again. And then it just continues like this. I just take the activities in very, very, very small chunks with proper rest in between.
So do you feel improvement of the?
Absolutely, absolutely. If you'd spoken to me 2 months ago, I probably would have declined the call because I would have just felt too exhausted to even think the thought of having a call. A month ago, I would definitely have had the call in bed. So it's very, very slow, but it's gradually getting there.
Dr. Hammond, so I assume that your pacing is also is part of your current routine.
Yeah.
So when do you think you'll go back to normal? What is your
mean,
projection?
That is the £1,000,000 question. I don't know. That's the problem. So I think for me, I would say all of the other symptoms have definitely gotten better, but I'm still really, really struggling with the breathing. And so I think I just had a chat with another physician yesterday, and she sort of was saying, I think it's time to maybe start a few more investigations into the breathing, some respiratory function tests and some other things just to see what's actually going on. I definitely have improved, as I said, 900 steps a day and feeling completely exhausted to now, even if I don't leave the house, I'm doing at least 4,000, 5,000 steps. So I'm able to do much more in the house. I think I'm still trying to, this group has really helped me a lot as well. And I ask them all the time, I'll write to them and say, look, I've just had 4 days where I've done nothing and my breathing feels a bit better. Does that mean I can't be walking anymore? I don't know. It's very much a trial and error. And I think that's what we've all really been doing, and why having sort of a few other people to sort of bounce the ideas off of, and to sort of be able to help you see, actually, you have improved massively in the last however many months. And, these things seem to be working, these things don't. I think, as Professor Garner said, because it is a virus and because we don't know exactly, the tests that we're all having are normal, but clearly something's still going on in our bodies. And it seems to be that we need to give our bodies the chance to recover. And I was just going to mention as well that we're all a part of quite a few groups online. One of them is all doctors. It's 280 doctors now, I think, 70 doctors. And the majority of us are improving without massive intervention, but it is very slow for all of us. And so I think we don't know a timeline. We are the ones where we are learning the timeline.
So are you back in your practice now? You teaching, or you?
I've not been back to work in almost 5 months now. So I'm hoping, I mean, I would say if the trajectory continues as it has been, I'm hoping within the next couple of months, I should be able to, do some work. But because I'm so breathless, even at rest, even just having a conversation for longer than 20, 30, 40 minutes continuously, which, as you know, with medicine, you talk all day long, is difficult for me. So, I think I need to see a bit more of a significant improvement with the shortness of breath before I can really continue to do full days at work. And even when I do go back, I'll go back part-time.
I see. So apparently more than 100 doctors communicate with each other, not only doctors, but also patients with that protracted disease. So do you use any special app for that, or just regular social media, Facebook, Instagram, or how do you communicate? You live in different cities.
We use it all.
Use it all, okay.
We've taken advantage of all social media.
So apparently it's quite prevalent, right? But we don't know specifically. A lot of anecdotal information about that. But I understand only one peer-reviewed study that reported long-term or protracted COVID-19 symptoms. It's the one that's done in Italy, in Rome, right? So they identified a single group of 143 survivors. It's a similar like your group, right? So they observed them as probably the cohort study or something, and they reported the worsening of quality of life in more than 40% of the cases, including symptoms of fatigue, breathlessness, joint pain, chest pain, and something. So obviously it's quite prevalent condition now. It's a phenomenon, and so healthcare system needs to do something with that. Maybe develop a rehabilitation system or something like that. It's very important. So do you think you mentioned about the infection, but scientists say that infection, the coronavirus actually persists in the body for about a couple of weeks, and then the immune system fight it, and then it's no longer infectious. So then with all that, with all the symptoms, disease gradually become a sort of chronic condition. So do you think that it's a chronic disease now, or it's still part of the more mild phase of the original infection? So how would you describe all this condition?
I mean, it's not chronic by definition, which is usually 6 months in the UK. We're coming up to that. That's why using medical terms sometimes doesn't always help, because we got a new virus and people are still ill with it. So I think, and you look at other viral infections that have these long tails, and Epstein-Barr virus, glandular fever, people talk about 6 months to 2 years to recover. So this kind of time frame is not unusual. What's going on pathologically, I don't know. Everybody talks about it on the Facebook pages about the virus is still circulating or it's not still circulating. I honestly don't know. I think we're not infectious. There's something still going on, and I think there's something still going on in our heads. I think there's some degree of influence over the autonomic system, but I'd be hesitant about making jumping to knowledge of the pathological process about accounting for it for us. But that is from my side, you know, the fatigue Lynn and Julia are expressing may be because of a different part of the spectrum, you know, that involves the heart or the lungs or whatever else. It's all a bit different. So I'm hesitant about lumping it all together, but being just very careful as we move forward. But I do think we all will get better.
Yeah, a lot of discussion about cytokine storm, but a lot of uncertainty now, and hopefully the scientists will come up with more specific treatment, not only for the infectious phase of the disease, but also protracted situation as you're experiencing now. So, Dr. Garner, you said that what to do in order to avoid any complications, and you said that not get infected again. So I don't know if I understood you correctly. So does it mean that a person who got infected once, it could be he could get infection second time, or it's repeatedly?
Who knows? You know, coronaviruses, people talk about 2 or 3 years. There are others that clearly know about this. I just wouldn't want anybody to have this condition, and I would avoid getting infected. And you know, once you've got it, who knows why some people have a long haul and others don't. I thought it was because I was old, but I look at Lynn, and you know, is a young person who's super fit, and Julia, both absolutely no health problems, and it's there. So it's not something that people should think they are immune to.
Thank you very much, and I really appreciate your insight about your condition, about current knowledge on COVID-19.
Same in Swansea.
Thank you very much.
Thank you.
Thank you so much. Thank you.